Hi everybody, my name is Suzanne and this is my presentation about an educational need among nursing staff. Recently I was hospitalized for a lap chole, and while waiting for surgery I was sent to the surgical ward in my hospital. I was wheeled back into my room at 17:30 from surgery, and by 19:30 I insisted to get up and walk. My husband and my sister thought I was crazy. When I made it to the nurse's station, my primary nurse also thought I was crazy for ambulating so fresh out of surgery. And this got me thinking, how many lengths of stays are increased because patients have prolonged immobility? How is pain affected by prolonged immobility? I knew why my sister and my husband were confused with my insistence to mobilize, but why were the surgical nurses, just as confused, if not more? Why is this not common practice, as best practice suggests that early ambulation 4 hours post-op leads to optimal recovery? Thus, the educational need for this assignment was hatched. Let's begin to unfold my educational plan. These are my objectives. By the end of the presentation, the audience will identify 2 reasons to ambulate a patient early in a post-op state, discuss 3 ways to encourage a patient to ambulate early, list 2 internal and external frame factors for this educational plan, describe 2 characteristics of the cognitive behavioral theory, predict a proposed budget for an educational program, and create an evaluation tool for an educational program and the individual learner. Section 1 will contain an explanation and an exploration of the educational need, internal and external frame factors, the cognitive behavioral learning theory, and the proposed budget and the evaluation tools. So, what is early ambulation? Early ambulation, as defined by Tazreen et al. 2022, is when a patient ambulates within 4 hours in a post-op surgical state. Early ambulation does not trump safety. This is an important concept because nurses get tunnel vision and think best practice methods is at an all-cost ordeal, and it's not. Always assess a patient for mobility safety. Check hospital policy with regard to ambulation post-op assistance, regardless of home baseline. And if concerned about safety, do not ambulate until those concerns are addressed. Certain medications will alter a patient's ability to ambulate. Anesthesia can impair a patient's ability to ambulate safely. Always be on the lookout for reasons not to ambulate your patient. Additionally, when you get your patient up for the first time, be there to assess the gait, the steadiness, length, level of consciousness, dizziness, BP changes, etc. Any of these factors can increase a patient's risk to fall, which can lead to patient injury, increased length of stay, and or death, depending on the age or mortality risk. So remember, safety first. That said, this slide shows statistics about early ambulation in studies conducted between June and December of 2019 on post-op lumbar patients. Huang et al. 2021 found a clear benefit to early ambulation through the study of in the evidence of ambulation distance and time post-op day 1 through 3. The early ambulation group was ambulating 280 meters by day 3, while the regular ambulators, those that ambulated greater than 24 hours after surgery, were only walking 190 meters. Additionally, early ambulators were walking 27 minutes at a time by post-op day 3, while regular ambulators were only walking 22 minutes. The early ambulators realized no complications, decreased pain reported, increased mobility, and earlier return to the normal ADLs within 2 weeks, while regular ambulators were taking 4 to 6 weeks. Between increased Foley dwelling time, increased pain medication use, increased length of stay, and increased financial burden, there is a clear need to ambulate patients earlier rather than after 24 hours. Here's a slide of all the benefits that can be realized through early ambulation. These are fun facts. Providing the best patient care possible is not catering or allowing the patient to remain comfortably numb. Part of our job as nurses, as members of the healthcare team, it's to push the patient when they're not able to push themselves. Encourage the patient by providing the facts about early ambulation, ensuring pain medication is on board prior to ambulating, and offering guidance and support during the first couple of walks. Encourage the patient through the entire experience by focusing on the accomplishments of the patient and offering affirmation. It takes a lot of discipline to get out of that bed after surgery, so encouragement and regularity will be a big factor in the patient's desire to continue. The patient will likely realize a shorter recovery time, shorter length of stay, decreased Foley time, decreased pain, less complications, decreased healthcare cost, faster mobility, and decreased mortality rate. Early ambulation case study. A 75-year-old female underwent an ORIF of the right hip after a fall left her with a fracture of the right acetabulum. She lives at home alone and reports that she is baseline independent with no assistance for ADLs. She looks to be her stated age and is well nourished. Should she be encouraged to ambulate early? This is a familiar scenario for my hospital, especially for the surgical units. For this case study, the nurse absolutely should anticipate the patient will be able to ambulate early. Of course, the nurse must assess the patient upon arrival back to the unit and follow all of the provider's orders. Since this patient is independent, lives alone, is well nourished, and needs no assistance for the ADLs at baseline, it is a realistic goal that the patient can return to that baseline after her surgery. Since the surgical unit in my hospital is affiliated with Sentara Health, I chose to use them as my parent institution. Their mission is to improve health every day. My educational need is congruent with this mission because it would, in fact, improve patient health every day. Next, the resources I would need to conduct the program would be a classroom. Classroom availability is widely open and generally not an issue. Lastly, the values of Sentara Health: people, quality, patient safety, service, and integrity. The values and my educational program are also congruent. The external frame factors are factors outside of the program. The community plays a role in the need for the educational program because they are the patients we provide the service to. The healthcare system. We have a duty and responsibility to instill prevention programs within the system based on evidence-based practice interventions such as early ambulation that will help return the patient to their baseline. Lastly, the need for the program. Teaching and training of healthcare professionals is a great need for the surgical team because the OR last year, in 2021, the OR alone realized over $11.2 billion in revenue. Think about how many patients it took for that number and how many length of stays we could have possibly cut even in half or by one day with early ambulation. The cognitive behavioral therapy theory is the theory that I chose to base my educational program around. I really like this theory because it's a form of active learning, and behavior is directly influenced by self-concept. And this can be positive or negative. Basically, the person has to realize self, world, and future. And where we learn that our behavior today influences our future of tomorrow, it kind of makes it concrete in your head that ambulating a patient decreases their length of stay, decreases healthcare costs, can influence the future of healthcare. And it's by putting these puzzle pieces together that you come to that conclusion that I need to do this now because of what it can do for me then. John Piaget is credited with founding the cognitive learning theory, and there are actually two branches. One is cognitive behavioral therapy, and the other one is cognitive social. The program budget for this program is $40,000. And the reason I came to this conclusion, because originally when I was writing out my budget, I said, okay, $100, and then we're going to get this done. And then I realized that It's not just about the free paper and the ink, and it's not going to cost me any money. And that I had to wrap my head around, how much is this going to cost the institution that I work for? And paper is not free. Ink is not free. Computer and classroom use is not free. So we budgeted 25% of $40,000 for that part. And then time. This is educator, participants, leadership. Everybody's time is wrapped up into this program. So again, it's not free. It has to be taken into consideration, especially because this program is not going to write itself. There's going to be revisions. There's going to be a lot of moving parts. And so all of that is time. And then we come to the biggest chunk, which is $20,000, and that's payroll. For my institution, whenever you have to attend a mandatory education, you are guaranteed an hour worth of pay, and our nurses range anywhere from $27 to $60 an hour for our surgical team. So that could be anywhere from $13,500 to $30,000. It all just depends on it all just depends on the number of $60 an hour nurses that attend this. So $40,000. Once I got to $40,000, I realized that even a simple training module that somebody can create for free is not going to be free for the institution. Important to note, budgets are always subject to change. Factors that would influence a budget change would be time, availability of the classroom, availability and cost of supplies, number, and the pay rate of the employees. Okay, this slide is a lot of information. Evaluations have to be thought of in 6 parts, according to Bastable 2021. The 6 parts are audience, purpose, questions, scope, and resources. The last part of the decision is between formal and summative evaluations. So to break it down, the audience includes the participants, and the purpose, is this evaluating the person? Is this evaluating the teacher? Is this evaluating the program? And this is an important question to ask, because then that brings us into, what questions are you going to ask? They have to be specific, measurable, clear and concise, and directly related to their purpose. That's why all of this is contingent on the other. The next is scope, the extent. Is it broad or narrow? Do we want the individual, are we interested in the knowledge, the content, the understanding, or are we interested in the short-term goals of the program, the learning experience, the understandability of the content, the time allowed for the program? Or are we are interested in the long-term effects of the program, which would be the eventual patient outcomes, the decreased length of stays, the decrease in complications, the decrease in healthcare costs. All of that could be, all of those results could speak to the evaluation of the program. The last one is resources. Are they accessible and available? Time, expertise, personnel, materials, equipment, etc. Were all of these resources allocated in a proper way? And then the formal versus summative. For my evaluation plan, I chose to look at the individual at a process and content evaluation stance, and then for the program, process and summative evaluation stance. So section 2 is all about the evals. The section is considerably smaller, and we'll discuss the different types of evaluations I plan to use for my educational program. In short, I plan to evaluate the individual learner and the program. The individual evaluation will consist of a return demonstration of safe ambulation within 4 hours post-op, while assessing all of the factors for safety. Some specific questions to evaluate the content of the program are to investigate the authenticity of the learning experience for this individual learner. This does not speak to the process, but only to the content or knowledge base acquired as a result of the program. Next, I plan to conduct a process evaluation, which will investigate the learning process of the program. And I've included here some specific questions that you would ask if you were in search of a content eval versus a process eval. And you can tell the content eval almost takes the learning objectives and flips them into questions that are being answered. And if you can answer the learning objectives, then obviously you got the content. The process eval is more so thinking about the whole learning process. Was it a comfortable environment? Was there active participation? Were people sleeping or were people actively answering questions? The information that is on the PowerPoint or given orally, are they congruent? Do you have enough time to answer the questions? Do you have enough time to ask the questions? It's the whole learning process, not the information that was gleaned from it. That's a very hard distinction to make. As the program, we have process and summative evaluations. I personally like a Likert scale for this one because you're basically asking the learner to evaluate the program based on the process. Again, was the teaching appropriate? Did the individuals learn? Were the objectives met? Did the nurse who learned a new skill demonstrate the ability to independently perform that skill accurately in practice? And it would just consist of about 10 questions, something very simple and quick, but powerful enough to give you good information and feedback that, yes, you're doing a good job with your program, or how you can always change your program. In summary, early ambulation is key to early recovery. Early recovery places less burden on the patient, the healthcare team, the community, and the insurance companies. Early recovery results in greater overall patient post-op experience. Internal and external frame factors must be considered in order to conduct a proper needs assessment. The cognitive learning theory will best be utilized in my educational plan. The monetary budget for my program is $40,000, and I plan to evaluate individual learners with process and content and program with process and outcome summative. And here are my references. I hope you enjoyed this presentation. I enjoyed creating it for you, and I will see you in the next course. Thank you.